Welcome to PRISM Rounds, the audio journal club, where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, physicians, trainees, nurses, pharmacists, and respiratory therapists. I originally started making these episodes to support my own learning and review, and I'm sharing them publicly in case they're helpful to other busy clinicians and learners. The episode uses AI-generated voices, so you may occasionally hear a mispronunciation of a medical term, drug name, or author name. Thanks in advance for your patience. Everything you'll hear is for education only and not medical advice. This week on PRISM Rounds, we ask whether auto-adjusted NIV can safely take some of the work out of treating obesity hypoventilation syndrome, delivering similar PaCO₂ improvement without the complexity and cost of sleep lab titration.
Imagine trying to discharge a patient who desperately needs positive pressure ventilation to clear their accumulated carbon dioxide. But then you realize the wait list for the formal sleep lab titration they need is stretching into, the next fiscal quarter.
Yeah, that is an incredibly common and frustrating reality.
Right. You know the exact physiology you need to fix, but the logistical bottleneck of human capital and lab space is completely paralyzing your care plan. So what if you could bypass that entire queue with a single algorithm?
That would change everything.
It really would. Welcome to PRISM Rounds, Season 1, Deep Dive 42. Whether you're an ICU attending, a sleep medicine fellow, a hospitalist, or an RT catching up on the latest literature, this deep dive is tailored for you.
Absolutely.
Today, we are looking at a highly practical clinical trial that sits right at the intersection of respiratory physiology, sleep lab logistics, and healthcare economics. We are focusing on a 2026 AJRCCM article titled Effectiveness of Automatically Adjusted versus Manually Adjusted Non-Invasive Ventilation in Obesity Hypoventilation Syndrome, a randomized clinical trial.
And we are also going to fold in the insights from its accompanying editorial to figure out how this actually translates to the bedside.
So the core question we are tackling today is this. Can a smart auto-adjusting machine replace the laborious manual sleep lab titration for patients with obesity hypoventilation syndrome, or OHS? Okay, let's unpack this.
It is a really critical paper, because it addresses a massive point of friction in our daily practice.
Definitely.
When you have a patient with OHS, the traditional pathway to get them on appropriate non-invasive ventilation is just incredibly resource-heavy.
Right, the polysomnography, the in-lab manual titration.
Exactly, and a lot of highly specialized technologist time. So this trial asks a very direct question. Can we bypass that specific bottleneck? Can we use this auto-adjusting machine for ambulatory patients with stable OHS without, sacrificing clinical outcomes over the course of a year?
Before we get into the algorithms and the trial design, though, I feel like we need to establish the baseline physiology.
Good call.
We are not going to bore you with the basic diagnostic criteria of OHS. You already know what you are looking at when these patients present to the hospital. But we need to look at why treating them is so much more difficult than a standard sleep-disordered breathing case.
Yeah, because the stakes here are incredibly high. If we leave this untreated, we are looking at recurrent hospitalizations, severe pulmonary hypertension, right heart failure,
and a significantly increased risk of mortality.
Precisely. What's fascinating here is that the physiology is a multi-layered mechanical trap.
A mechanical trap, I like that.
Yeah, you have massive truncal obesity causing severe mass loading on the chest wall and the diaphragm.
Yep.
That drastically reduces respiratory system compliance and crushes their functional residual capacity.
So they are breathing at very low lung volumes.
Right. They are right on the absolute worst, flattest part of the compliance curve, which means their work of breathing is astronomically high.
Now, I want to push back a little on how this is often taught, or, well, at least how it is frequently perceived by residents on the wards. Let me play devil's advocate for a second.
Sure, go for it.
A common misconception is that OHS is essentially just severe obstructive sleep apnea with extra weight. The thought process is, if a patient has an apnea-hypopnea index of 70, isn't the chronic daytime hypercapnia just a byproduct of all those nighttime apneas?
I hear that all the time.
Right. Why does the hypoventilation component require a totally different approach?
Well, that is exactly the misconception we have to break down. Yes, about 90% of OHS patients do have concomitant obstructive sleep apnea, and often it is severe.
Okay.
But the pure hypoventilation component adds a massive layer of complexity that goes way beyond just the airway collapsing.
How so?
Because their mechanics make it so exhausting to breathe, over time, they start to hypoventilate even when they are awake. This leads to chronic carbon dioxide retention.
And then the renal compensation kicks in.
Yeah, exactly. As their kidneys retain bicarbonate to compensate for the respiratory acidosis, that elevated bicarb crosses the blood-brain barrier, and that fundamentally blunts the central medullary chemoreceptors.
Wow.
So it is not just that their airway closes, it is that their underlying neurological drive to clear the CO2 is fundamentally impaired. Their brain has essentially accepted a higher CO2 as the new normal.
Which perfectly explains why the historical gold standard for treating this complex physiology has been the full in-lab manual titration study.
Right, because you have to treat both issues.
Exactly. To fix both the airway collapse and the blunted central drive, you put the patient in a sleep lab. A specialized technologist watches their waveforms all night and manually dials in the fixed inspiratory and expiratory pressures in a spontaneous timed mode.
It is a lot of precise tweaking.
Yeah, they need to simultaneously stent the upper airway open with the EPAP, provide enough pressure support with the IPAP to augment their tidal volume and clear that CO2.
And set a backup respiratory rate just in case their central drive drops out entirely.
Exactly.
It is a beautiful, highly customized process when it works. The technologist is constantly balancing the pressures against the varying stages of sleep, like REM sleep, when muscle atonia makes the mechanics even worse.
But as we all know, it is incredibly slow.
Painfully slow. Sleep lab beds are scarce commodities everywhere. You know, a patient gets discharged from the hospital after a hypercapnic exacerbation. They clearly need complex, non-invasive ventilation, but they simply cannot get into the lab for a formal titration for months.
And since we cannot magically build more sleep labs and train thousands of new sleep technologists overnight, this article asks if technology can step in.
Right. Can an algorithm do the heavy lifting?
Let's talk about the study design. The investigators set up a multi-center, blinded, parallel group, randomized non-inferiority and cost-effectiveness trial.
That is a mouthful.
Yes. It was conducted across 12 different sites in Spain, ultimately including 196 treatment-naive ambulatory adults with stable OHS.
Specifically, there were 186 patients included in the intention-to-treat analysis.
Right. So the trial randomly assigned these patients to either the traditional manual pathway or a completely auto-adjusted pathway.
Let's break those down. In the manual NIV group, patients received the standard of care. They were placed on bilevel positive airway pressure in spontaneous timed or ST mode.
So daytime adjustment followed by a full in-lab polysomnographic titration?
Exactly. That locks in their specific fixed pressures. But the intervention arm is where the technology really takes center stage.
Yeah, the automatic NIV group utilized volume-targeted pressure support combined with auto-EPAP.
That dual algorithm approach is key.
I actually have a question about how the auto-EPAP functions, because I think we throw the word algorithm around a lot without explaining the mechanics for our trainees.
That is very true.
How exactly does the machine know to increase the expiratory pressure without a human watching the screen? Like, what is it actually detecting?
That is a crucial point for anyone managing these devices. The auto-EPAP algorithm is constantly analyzing the patient's inspiratory flow contour.
Okay, looking for changes in flow.
Right. When the upper airway starts to narrow, even before a full apnea occurs, the shape of the inspiratory flow curve changes. It loses its nice rounded peak and becomes flattened, which is the classic sign of flow limitation.
Oh, interesting.
The algorithm detects that flattening and incrementally increases the expiratory positive airway pressure to stent the airway open until the flow contour rounds out again.
Okay, so that handles the obstructive sleep apnea component, but what about the hypoventilation?
That is where the volume-targeted pressure support comes in.
I usually explain this to trainees by comparing manual NIV to bespoke tailoring, requiring multiple fittings, experts measuring every angle, highly resource-intensive. And I compare auto NIV to a sort of smart fabric that dynamically adjusts to the wearer's body in real time. Or another analogy is driving on cruise control on a hilly road.
The cruise control metaphor is fantastic.
Yeah, you set a target speed, which in this case is a preset target alveolar ventilation based on the patient's height and ideal body weight. If the truck hits a steep hill, say the patient enters REM sleep, their muscle tone drops, and their chest wall becomes a massive mechanical load, the engine has to dynamically rev up.
Exactly. The machine automatically increases the inspiratory pressure, breath by breath.
Right, to maintain that strict target ventilation against the shifting gravity of their own body. If the road flattens out, the pressure support backs down.
The machine is continuously sensing the patient's minute ventilation and dynamically expanding or contracting the pressure support delta to guarantee they clear the CO2, regardless of sleep stage or sleeping position.
Incredible. So the trial's specific goalpost was to see if this dual algorithm approach could match human expertise.
Yes, the primary outcome was the change in daytime arterial PaCO₂ at 12 months.
And because this is a non-inferiority trial, they established a strict margin of 2 millimeters of mercury, right?
Correct. As long as the automatic machine was not worse than the manual titration by more than 2 millimeters of mercury on an arterial blood gas a year later, it would be considered a success.
Here's where it gets really interesting. Let's look at the physiological signal, because we are asking an algorithm to manage incredibly complex changing mechanics over a full year. Did the smart fabric actually work?
The signal was undeniably clear. In the intention to treat analysis, both groups saw a very substantial, clinically meaningful improvement in their daytime hypercapnia.
Okay, what were the numbers?
The auto-adjusted NIV group saw their PaCO₂ drop by about 9.2 millimeters of mercury. The manually adjusted NIV group dropped by 8.7 millimeters of mercury.
Wait, so the auto actually did numerically better?
It did. It easily met the pre-specified non-inferiority criteria.
Wow. A drop of 9 millimeters of mercury in an OHS patient is totally transformative. But my immediate concern when I see an algorithm aggressively pushing pressure to meet a strict volume target is patient ventilator desynchrony.
That is always the worry, yeah.
Right. If the machine is indiscriminately firing high inspiratory pressures at a patient whose airway is closed or pushing too hard when they are trying to exhale, the patient is going to rip the mask off. Did they look at patient tolerance?
They absolutely did, and the secondary outcomes are vital here for exactly that reason. The article shows that the machine did not achieve that ventilation at the cost of the patient's sleep quality or comfort.
Okay, that is reassuring.
Almost everything else was similar between the two groups. The improvements in pH, PO2, and serum bicarbonate were all comparable.
What about the sleep metrics?
When they looked at polysomnographic measures at 12 months, the reduction in the apnea-hypopnea index and the improvement in sleep efficiency were similar.
So we didn't see massive sleep fragmentation from the algorithms chasing targets.
Correct. Furthermore, patient-reported outcomes like the Epworth Sleepiness Scale and health-related quality of life showed parallel improvements.
And functional status.
Objective functional measures like spirometry and the 6-minute walk distance improved equally. Even hard clinical metrics like blood pressure, mortality, and adverse events showed no meaningful differences.
So the algorithm provided holistic clinical stability that perfectly mirrored the resource-intensive manual titration.
Exactly. But the trial wasn't just looking at physiology. It was heavily focused on healthcare economics.
Ah, the financial kicker.
Yes. The cost-effectiveness analysis heavily favored the automatic NIV pathway.
By how much?
By completely avoiding the in-lab titration studies and reducing with associated technologist labor, the auto-adjusted pathway saved approximately 1,528 euros per patient over the 12-month period.
Wow, 1,528 euros. Is this just about saving euros, though, or is the real value in freeing up the sleep lab for the patients who genuinely need complex manual care?
It is absolutely about reducing friction in a high-burden disease state. It is about unbottlenecking the system.
Right. If you can confidently start a straightforward OHS patient on an auto-adjusting device and achieve non-inferior physiological outcomes, you get therapy to that patient weeks or months faster.
And you reserve your highly specialized, scarce sleep lab beds for the truly refractory cases, the complex neuromuscular disorders, or the patients with central sleep apnea who absolutely require human intervention and complex diagnostics.
Precisely. Now, having established that the technology clearly works and saves resources, we have to transition to the editorial.
Yes, the editorial is crucial here.
Because reading a clean, highly controlled trial in Spain is one thing, but translating that to a busy clinic in Chicago, London, or Toronto is a completely different reality. How does this actually change practice, and can you even get these machines for your patients?
The editorial provides some very needed real-world nuance. The first major point it makes is a warning against over-extrapolating the data.
Meaning we shouldn't just throw out CPAP.
Exactly. We must not misinterpret this trial to mean that auto-NIV replaces simple CPAP for everyone with obesity hypoventilation syndrome.
That is a very important distinction for anyone writing these prescriptions. For a large phenotype of stable ambulatory OHS patients, particularly those with severe obstructive sleep apnea, simple continuous positive airway pressure remains the conditionally recommended first-line therapy.
Right.
Why is that, though? If we know auto NIV clears CO2 so well, why not just use it for everyone?
Because for many of these patients, their daytime hypercapnia is primarily driven by the sheer volume of severe obstructive events at night.
Right, they're spending all night fighting a collapsed airway.
Exactly, so they never get the chance to blow off their CO2. If you simply apply CPAP to stent the upper airway open and eliminate those apneas, you remove the primary mechanical load.
And then their intrinsic respiratory drive recovers.
Over time, yes, it can often recover and clear the accumulated CO2 on its own. CPAP is vastly simpler, it is universally available, and it is highly effective for that specific phenotype without needing complex pressure support algorithms.
So if CPAP is still first line for the severe OSA phenotype, when exactly are we reaching for this auto NIV technology?
Its strongest role is precisely when non-invasive ventilation is strictly indicated over CPAP. That includes OHS patients who do not have severe OSA, where the primary issue is pure hypoventilation and altered chest wall mechanics.
Okay, that makes sense. Who else?
It is vital for patients who are recovering from an episode of acute on-chronic hypercapnic respiratory failure and require ventilatory support upon discharge. It is also the go-to therapy for patients who simply cannot tolerate high-pressure CPAP, or those who remain highly symptomatic or persistently hypercapnic despite strict adherence to their CPAP therapy.
Got it. So when you make the clinical decision that a patient absolutely needs bi-level ventilation, that is when auto NIV becomes a highly validated, efficient option.
Exactly. But identifying the right patient is only half the battle.
Oh, don't I know it? Actually, prescribing the machine and getting it delivered to the patient's home introduces a maze of regulatory and reimbursement realities, particularly in the U.S. healthcare system.
The editorial spends significant time highlighting these geographic access issues.
Yeah, the U.S. access landscape is just a labyrinth. To even qualify an OHS patient for non-invasive ventilation, Medicare and private insurers require a mountain of objective testing.
It's exhausting just thinking about it.
You often need to document an in-lab polysomnogram anyway, just to prove they have the disease. You need spirometry, you need sequential daytime arterial blood gases to prove they are retaining CO2.
And you often need specific nocturnal oxygen assessments to prove they have failed simpler therapies like CPAP first.
Right, and it gets even more complicated with the specific device algorithms themselves. In Europe, simpler, less expensive, non-invasive ventilators frequently come equipped with these advanced auto EPAP and volume-targeted pressure support algorithms built right in.
But in the U.S., getting that specific combination of algorithmic features often requires you to prescribe a vastly more expensive home mechanical ventilator rather than a standard respiratory assist device.
It is a massive point of frustration for pulmonary and sleep physicians. The technology exists to streamline care and keep patients out of the sleep lab, but the reimbursement criteria are entirely circular.
They force you back into the sleep lab just to generate the paperwork required to get the auto-adjusting machine approved.
It is a universal truth of modern medicine. Sometimes the respiratory physiology is vastly easier to solve than the insurance approval.
Oh, absolutely.
You can titrate the perfect alveolar ventilation in your head. You can calculate their ideal body weight minute ventilation perfectly. But trying to get the durable medical equipment company to actually deliver the device with the right algorithms enabled is the real clinical challenge.
The editorial rightly points out that while this trial proves the clinical efficacy of auto NIV, the next frontier is not physiological, it is administrative.
We really have to advocate for sensible payer policies that actually allow our patients access to this cost-saving technology without forcing them through unnecessary diagnostic hurdles.
Completely agree.
So, what does this all mean for your practice tomorrow? Before you step into your next clinic or step onto the wards, we need to responsibly frame the boundaries of the article's findings. What are the limitations, the clinical blind spots we need to be aware of?
Every trial has limitations, and you have to know them before changing your practice. First, it is a single-country study conducted entirely in Spain.
And healthcare delivery varies wildly, right?
Very much so. Sleep lab accessibility and specific device costs vary across different countries, which means you cannot perfectly generalize their cost-effectiveness data to a hospital in the U.S. or the U.K.
Fair point. What else?
Second, and most importantly for the intensivists and hospitalists listening, the investigators strictly enrolled stable ambulatory patients.
Meaning we cannot blindly apply these results to the acutely ill, hospitalized OHS patient who's currently in the ICU or step-down unit recovering from a massive exacerbation.
Exactly. An acutely ill patient has constantly shifting airway resistance, massive changes in lung compliance due to fluid shifts or atelectasis, and varying levels of consciousness.
Those rapid physiological swings might completely confuse the auto algorithm.
That acute population needs to be studied prospectively before we even think about abandoning manual bedside titration in the hospital setting.
We also have to acknowledge that the shadow of COVID-19 impacted this trial. The pandemic struck right during the follow-up period, which meant that some of the more time-consuming secondary testing, like the 12-month spirometry, the 6-minute walk tests, and the follow-up sleep studies, had incomplete data collection.
The authors use robust statistical imputation to handle the missing data, but, it is a limitation nonetheless.
Of course.
Finally, we must recognize that the trial was powered for a physiological surrogate endpoint, the change in daytime PaCO₂. It was not powered to detect differences in hard clinical endpoints like long-term mortality or hospital readmission rates.
Even though the secondary data we do have is very reassuring. Let's distill this into the bedside bottom line. If you are sitting in clinic tomorrow with a stable ambulatory patient with obesity hypoventilation syndrome, and you have made the clinical decision that they require non-invasive ventilation, perhaps they failed CPAP or they don't have severe OSA to begin with, this trial provides strong evidence that prescribing an auto-adjusted NIV device is clinically non-inferior to sending them for a manual in-lab titration.
Right. It effectively improves their daytime hypercapnia over a 12-month period. It maintains their sleep quality, and it fundamentally reduces both the cost of care and the burden on your local sleep lab.
But, and this is the crucial caveat to remember, it does not replace your clinical judgment. An algorithm cannot take a proper history.
Never. It does not eliminate your job of phenotyping the patient, deciding who should start with a trial CPAP first, determining who truly needs to step up to NIV, and ensuring close, continuous clinical follow-up to monitor their adherence.
The machine is a brilliant tool, but you are still the architect of the care plan.
Well said. This raises an important question. We have seen that these auto-titrating algorithms are highly capable of managing complex respiratory mechanics over a 12-month period in stable patients.
Right.
They are continuously collecting massive amounts of data on flow limitation, respiratory rate, and minute ventilation every single time the patient puts the mask on.
I see where you're going with this.
If the technology is already this responsive and adept at analyzing physiological waveforms, how far are we from these same devices using predictive analytics? Could the home ventilator detect the subtle early physiological signatures of an impending acute on chronic hypercapnic exacerbation days before the patient actually ends up in your emergency department?
Oh, wow. That is a massive thought to leave on. That is where respiratory technology could truly change the natural history of this disease, moving us from reactive treatment to proactive prevention.
Thanks.
This has been PRISM Rounds. This episode is for educational purposes only and is not medical advice. The voices are AI-generated, so occasional mispronunciations may occur. Please follow or subscribe if you find these episodes useful.
Thank you for spending your time with PRISM Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve, pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.